Hello. Thank you, Dr. Minle, and of course, Dan and Dr. Tran, and for the kind invitation from Ipsen. So I do thank Ipsen for the kind invitation. And my talk will be on post-stroke spasticity and perhaps dwell on the early interventions. These are my disclosures, and I'd like to share to you the coverage that will focus on the context of timing and the use of botulinum toxin, looking at early interventions, and at the end, I focus on early versus late interventions, botulinum toxin therapy for spasticity. This slide is busy, but it only tells us one thing, that when we talk about the clinical features of spasticity, there are many other factors to be confounding variables to be looked into, one of which is pain, and the other will be the co-contraction and, in fact, even dystonia. If you look at the decursus morbi of any patient who develops stroke, you can see that we sort of divide this into certain stages, and our stroke specialists, one of the best in the continent, from Asia, I'm sure, we do see a lot of strokes, and they are treating a lot of patients on the hyperacute stage. And more we see patients who are doing better post-stroke. But if and when they are unable to improve, then we go into a stage of spasticity, and we have a certain definition of what is termed as subacute, which is less than 3 months, and the chronic, which is more than 6 months. So, okay, so the key thing that is often discussed is, why is it that it is the upper limb spasticity that you have a lot of clinical trials focused into? And this is just an example of a patient of ours who has severe spasticity, and one will argue that this patient is in a natural position and perhaps going into dystonia, spastic dystonia. And of course, if you do force it, you will see some excoriations in the skin, which is a practical point upon which we can perhaps intervene doing botulinum toxin. And if you look at the 6-month functional recovery of stroke patients, you can see that it is the upper limb motor function that is really on the low side compared to the other factors that you can see, including lower extremity. So the upper extremity is an important target for treatment and a focus upon which we should be doing more efforts in terms of treatment. Now, here is another point. This is a busy slide, but I wanted to share to you the fact that if you do have a stroke, like a left MCA infarct, you can see in this dynamic fMRI study, you can see this is the corticospinal tract. And if you just quickly look at the summary of this, you can see that most of the lesions are really impacting on the corticospinal tract, mainly subcortically. And if you plot it against the neural component and the function of the hand, you can see that those with lesions are really having the poorest function when it does impact on the corticospinal tract. So I will just move back and share to you this summary that we did in the long past, looking at the negative and the positive signs of spasticity. So you have the immediate consequences, so what we call the negative signs of spasticity, which is paralysis, which is actually making it more challenging than is dystonia injection. because in spasticity, you have weakness just as well. And so therefore, this is a big point and a huge difference between spasticity management versus dystonia, and especially in regard to botulinum toxin therapy. And the delayed consequences there too will happen if you don't intervene, one of which is contracture, which is very important in view of the effect on the biomechanical forces related to the joints, to the muscles, and to the tendons. So in the long past, we had this cartoon. We wanted to show you what happens if the lesion is less than 3 months. And if lesions in the stroke is less than 3 months, you can see that mainly it's the neural component that is working on it. But if you let it go beyond 3 months, then biomechanical forces will set in, whereupon established spasticity will happen, and you will have disabling spasticity and the learned non-use phenomenon. That is why we coined the term in the literature, evolving spasticity, for those less than 3 months. Okay, so this is a busy slide, but just bear with me regarding new definitions of spasticity in regard to botulinum toxin therapy. So we might tweak the definition of spasticity because now botulinum toxin is a level A recommendation for treatment. And you can see here that dystonia is a phenomenon, contractures is a phenomenon, but pain is a very important aspect related to botulinum toxin therapy in definitions of spasticity. Now, there are various causes of spasticity. It could be supraspinal or even spinal. So that is the reason why we see it in MS and even in childhood spasticity. There are many therapeutic options to do. It's not only in the realm of botulinum toxin, so that's not going to be my talk this afternoon. I just focus on the botulinum toxin. Now, people living with spasticity experience different treatment journeys, and this is open what happens in stroke. So you can see that they have multiple comorbidities. The time to onset is very important. Within 3 months, 20% of patients with stroke immediately develop spasticity, and it immediately doubles after a year. And so this is an important phenomenon to remember in terms of the journey of our patients with spasticity. And that is why in the comprehensive person-centered approach, consensus-based framework of treatment by Lynn Turner-Stokes and her group from UK, they advocated that in terms of our strategies, it's looking at the patient-centered care strategies and aims, and of course, it includes botulinum toxin. Now, other than botulinum toxin, you will see that there are other treatments that are happening. And so we must be aware that oral medications have been tried. Physiotherapy in tandem with botulinum toxin is very important. Surgery also is there, but you can see that most of our patients are in fact receiving oral medications other than physiotherapy. So these are the botulinum toxin medications that are having robust studies worldwide. And so we have ONA botulinum toxin, ABO botulinum toxin, INCO botulinum toxin, and RIMA botulinum toxin. Now, if you look at the effects of botulinum toxin as a basic thing, you can see that when you inject botulinum toxin, it will just have a direct chemodenervation in extrafusal muscles, but also intrafusal muscles. And there, it has also its effects on the vasculature, because the vasculature have also some neuromotor sympathetic tone effects. If you relax that muscle, corresponding tendons and joints where you have also organs can be impacted upon. And then there could be sensory modulation because of the effect of the intrafusal muscle fibers going to the spinal cord and eventually affecting spinal cord and supraspinal effects centrally. And do we have an evidence for that? Here is a nice study from Czech Republic, where they looked at the effect of botulinum toxin before injection at T1. And then here is what happens before injection here. And then here is T1, 4 weeks after injection. You can see that it becomes less and less in terms of fMRI changes. And then after 12 weeks, it goes back to the previous ones. That's very interesting. Now, of course, the therapeutic uses of botulinum toxin, I will just be very quick here. Other than spasticity and dystonia, it also includes pain. And so let's be aware of that. So here is a patient of ours, because I reckon that this session is also case-based. Here is this lady. She is 58 years old, and this is an actual injection just recently done in July, where she had a stroke at 54, and this is how she looks. Her problem, she had severe shoulder pains on the left. She can't dress by herself because of the pain. She had palmar hygienic problems and having some smell and odor in the palm. She has difficulty reaching and releasing items. And of course, she cannot participate so well in rehabilitation, and she feels that it's not helping her. So we did botulinum toxin, even if these were 4 years down the line from the time that she had a stroke. And so these were I have to come back. Okay. Sorry. So these were the areas where we injected. The shoulder mover, we thought of injecting some other shoulder muscles because of the shoulder pain, but I said, let's just try first the pec major, and then the elbow movers, and then the wrist movers, so that we can also go into the long finger flexors, so that we can do something to that hand in that position. 4 weeks after botulinum toxin, and this is, by the way, 4 years down the line after the stroke. She had 50% improvement in shoulder pain. She can now be assisted in dressing. Her palmar hygiene has improved, and she was happy to participate in rehabilitation care. So that is the usual thing that we see in the clinics with spasticity. But the other reason why I showed the slide is I want to mention pain. Pain in spasticity is an important phenomenology. And they say that if it reaches 60% in dystonia, it could easily be 20 to 40% in spasticity. And if you look at the muscle-based pain studies that were impacted upon by botulinum toxin versus the non-muscle-based pain studies, I refer, for example, to trigeminal neuralgia, I refer to diabetic painful neuropathy, I refer to complex regional pain syndromes. If you differentiate the two, muscle-based pain versus non-muscle-based pain injections, you can see that in this forest plot, the diamond is really towards less than 0, meaning that it does have an impact on muscle-based pain and non-muscle-based pain. Now, of course, this was published in 2016 in terms of the guidelines from the US, but we have a new guideline that is upcoming and published. So, clinics, practical. You have a case with spasticity, what do you do? So if you have a vial of abobotulinum toxin, 500 units, of course, there is a 300-unit vial. And you have another vial of ONA or Inco of 100 units. You mix, for example, saline, 2 ml for the ONA/Inco, and you end up with 5 units per 0.1 cc. For the abo, you mix it with 2.5 ml, and you end up with 20 units per 0.1 cc. So you have, therefore, what is referred to as low dilution. If you dilute low, you have a high potency, and you try to confine the toxin within the area of injection, so therefore less spread is expected. And if you double the dose, then you will have wider toxin area and spread is more expected, especially in larger muscles. So the best principle to follow that I always tell my students and my residents is always use the 1 ml syringe. And low dilutions are preferred for small muscles, and high dilutions are preferred for big muscles like the hamstrings and the biceps. And again, of course, this is not a sanctioned thing by our gracious sponsor, but let me just tell you that in cervical dystonia, these Korean experts ended up with a ratio of 2.5 units of abobotulinum per 1 unit of Inco botulinum toxin. So therefore, we use this in the clinics. Now, what about the pathophysiology? So let's just read this together for you to understand. I thought it's better to read this. So, in patients with finger flexor spasticity, there is an inability to activate the extensors because of diminished voluntary activation from corticospinal damage, or co-activation by the spastic flexors secondary to a hyperexcitable reticulospinal tract after loss of inhibition, over there that you can see. So what happens? Understanding these two separate mechanisms underlie the impaired voluntary control of upper limb extensors in the critical management of spasticity. Especially spastic flexors could be therapeutically weakened by botulinum toxin. If you therapeutically weaken the spastic flexors, residual weak extensors may be able to function adequately, since the primary goal of the extensor is to open the hand or extend the elbow in preparation for functional operation by the flexors. So this is what is referred to as the impact of botulinum toxin in spasticity, inducing what is referred to as therapeutic weakness. Okay, so let's have a proof for that. If you look at the pre-injection here in terms of the timing from the flexor digitorum superficialis versus the extensor digitorum commonis in terms of the time, for example, in seconds, from the grip and release. And you can see that that's drastically shortened, both in the flexor, but also in the extensors. So these are impacted upon by botulinum toxin. And this is an electrophysiologic proof that botulinum toxin does impact on the co-contraction of the flexors and the extensors. Now, nicely, we, of course, know this, that the onset of therapeutic effect will be in the tune of about 12 days or about 2 weeks. It peaks up on the 5th week, usually in this, looking at several studies, and then symptoms re-emerge. And then by 12 weeks, and then you re-inject after 3 to 4 weeks. So this is the usual thing that happens. And the reason why I showed you that is I wanted to show you another thing, that if you do have that kind of a course in botulinum toxin therapeutic effect, therapeutic weakness, so to speak, if you have the maximum effect here, and the effects start to wean off here at this time, and that will be looking at various parameters just as well. It's not only looking at stiffness, but also using the arm, muscle spasms, and even on the leg. So these are very important things that can happen. Now, I would like to switch gears into shoulder spasticity and shoulder injection with botulinum toxin. Many years, we used to inject the elbow movers, the wrist movers, and the long finger flexors. But nowadays, we believe, as I believe, that it could be that we might be missing the boat in terms of our injections because many of the patients do have more pain in the shoulder than in the elbow or in the wrist. That was the example of the patient that I showed you earlier. That kind of a situation is very important because if you give botulinum toxin, the pain reduction is very, very much high in terms of botulinum toxin. So therefore, maybe if you do proximal injections, which is actually the thing that we don't do routinely, we can impact more in terms of function of our patients here. Passive function, active function, mobility, involuntary movement, and impairment, if you look at those with shoulder pain versus those which are non-shoulder pain. So nowadays, we inject also the shoulder movers, very important in terms of our management of botulinum toxin. Okay, so we can also look at it in another aspect other than those that I mentioned earlier. It could also be in dressing here, shoulder population, hygiene, limb position, and here. Pain is very important in the terms of proportion of patients improving with botulinum toxin. Okay, so now how can we improve current practice of spastic paresis? We mentioned already about shoulder injections, and we mentioned about the pathophysiology of spasticity and how botulinum toxin can impact on it. But now we look at how else can we improve botulinum toxin effect in spastic patients. And now we are looking at early interventions, less than 3 months, I mentioned to you earlier, where mainly the neural components are working and the non-neural components are not working yet. So if you do early interventions, you end up with altering the time course of spasticity, perhaps modifying, maybe not preventing, but modifying the course of the spasticity and delay re-injection and prevent early contracture. So these are the things that we could perhaps improve in our current practice of botulinum toxin therapy. So let's look at early intervention. If you look at early intervention studies in the upper limb, you can see that when it comes to hypertonicity, early intervention studies does show that it impacts on hypertonicity, especially in weeks 4 to 12 post-injection. The same is true with the disability or the passive limb functions, especially if you do a sub-analysis looking at disability in the upper limb. Now, pain reduction is also there, you can see. Although it touches 0, it's telling us that there is a trigger there that perhaps botulinum toxin could be effective in reducing spasticity-related pain. So, we do have a local trial that have been done here in Asia. And we did have 2 publications related to that. And I do thank my co-workers for having done this job with us. This was graciously sponsored by Ipsen. And we do thank Ipsen for sponsoring these 2 clinical trials. And these are the countries that were involved in that study, in that endeavor. We enrolled patients who have early post-stroke spasticity of less than 3 months. And we looked at a number of things. The older one was the ABCDES trial, or the Asian Botulinum Toxin clinical trial designed for early spasticity, and the on-time trial, which came after that. So if you look at the modified Ashworth scales in the ABCDES trial, you can see that it has drastically reduced after botulinum toxin at week 4 and week 12, and the same with the on-time trial. By the way, the difference between on-time trial and the ABCDES trial is that in the on-time trial, this time we focused on re-injection. Can we delay botulinum toxin re-injection in patients with post-stroke spasticity? That was the research question for on-time trial. the research question for ABCDES is, can botulinum toxin impact on the post-stroke spasticity-related hypertonicity with early intervention? And these are the, obviously, the effects are clear for the ABCDES and the on-time trials. And you can see how the study will be summarized this way. So on the on-time trial, for example, with abobotulinum toxin, by the way, in both trials, we only used 500 units of abobotulinum toxin, not more, not less. It's always 500 units injected, and both trials were placebo-controlled. And I'm not going to mention the details anymore, but we have the publication. Anyway, if you look at the on-time trial, you will have 156 days more compared to 32 days in terms of re-injection, which means to say that you increase the re-injection time when you give early intervention with botulinum toxins, which is actually the time point that we targeted in terms of the on-time trial. So abobotulinum toxin is well tolerated, and in both studies, improvements in muscle tones were greater in abo compared to placebo. On time demonstrated that the time to fulfill re-injection was significantly longer. So again, 156 days as against 32 days with abo compared to placebo. So as to why the active arm function was not really impacted on both studies, we can venture on many reasons, but we could look at the milieu of vasculature in stroke patients, and of course, perhaps what we did in the scales were not very sensitive. So this is the summary of those studies comparing early versus late intervention. In the on-time trial, 2 in 5 patients did not require retreatment in week 28. That's very important after 6 months. In the adult upper limb spasticity done by Jean-Michel Gratchis and his group, 1 in 10 patients did not require treatment for 6 months. 2 in 5 patients were eligible for retreatment. So basically, the longer duration effect of botulinum toxin in early intervention trials. Okay, so let's look at the other studies. More studies came. Here we have Georg Wiesel from Germany who did a study. And if you look at the authors, this was also run by Ipsen. But at the end of the day, they also looked at comparing early versus late treatment, therefore. And what happened was that they found out that in all their cohort of patients, it seems like the early start interventions were having a tendency, but not significantly, compare better than the chronic late intervention in terms of reduction of the modified Ashworth scale for hypertonicity. And if you fragment that into those who are treatment naive and those who have been treated, the same happens. But it appears like the impact is more on the treatment naive patients. In fact, in our on-time and ABCDES trials, we engaged treatment naive patients. So, but here is a study. I think this is published where John Truong is an important member of the editors here. This was a study that was interesting, and I had the pleasure to review this study. Looking at early interventions, this was from the University of Texas group, and they looked at early versus late start botulinum toxin injections. But what is interesting here is that they tried to use higher doses of botulinum toxin in early intervention. And they believe that if we use higher botulinum toxin doses in early intervention, you will have a longer duration of effect. So that is the contention that this group has passed forward, that if you do early intervention at high doses, you could perhaps induce longer duration intervals between injection. And here is another study that has just been published 2 years back, wherein it is very, very clear that when they divided patients less than 3 months and after 3 months from stroke, you can see that those who were given botulinum toxin less than 3 months had greater reduction in muscle tone and also had longer inter-injection intervals. So this is another study independently done. And so this is just to mention to you here the modified Ashworth scale. Weeks later, it has been reduced significantly. And if you look at the impact not only on the upper limb, but it does also have impact on the lower limb, even if you just injected the upper. So that's an interesting study. So let me just, towards the end, I just wanted to tell you that there are a lot of guidelines already looking at the use of botulinum toxin in spasticity, including stroke, multiple sclerosis, and CP, and they are best used in chronic spasticity in the past, and early interventions may modify now spasticity progression, prevent contracture, and delay reinjection, and may potentially restore the balance of joints that have been focally reduced because of spastic co-contraction, dystonia, and associated reaction. However, it is a cardinal rule that I do in the clinics that I always do botulinum toxin in tandem with rehabilitation. And of course, the beauty about botulinum toxin is you can tailor fit it and you can target the muscles, and whether you do instrument guidance or not, that is one other thing. And correct dosing is very important. I mentioned about high potency, low dilutions for small muscles and low potency, high dilutions for large muscles. It's a very good rule to follow, and I still follow it up to now. We have to be very careful in the caveats of injection, where perhaps you could be injecting muscles which are protective to the patients. For example, the thigh muscles. So, towards the end, I just want you to know that there are modifiers of botulinum toxin doses. When you give botulinum toxin, what could potentially modify the effects of your toxin? And these are the modifiers: pathological muscle hyperactivity, agonist muscle, pathological muscle activity limited, pathological muscle activity functionally useful. These are the dose-modifying events that could potentially allow you to increase the dose or reduce the dose of your botulinum toxin. So this is another study by Lynn Turner Stokes. And this time, she compared botulinum toxin ABO versus ONA and INCO using the goal attainment scaling, which was their primary goal of achievement. And so you have here achieved versus, these are the set goals and these are the achieved ones. And as you can see, it appears like when you put all the three toxins together, you can see it from your distance that using the goal attainment scaling, ABO botulinum toxin fared better than ONA and INCO botulinum toxin. So here is another study of my friend Jacinto from Brazil, and he shared me this paper, and this is a very interesting paper because they looked at the patients themselves in a large cohort and asked them a number of questions, which is the one that will impact more in their perspective regarding the use of botulinum toxin. And you will be surprised that they needed benefits that will last longer. They wanted a toxin that will last longer. So I think that this is the prevalent view. Of course, we cannot generalize this, but this is a recent publication in a real-life scenario. So again, here is another new study that also showed that we have to identify factors predicting treatment discontinuation. What are the factors that will discontinue treatment of botulinum toxin? And here, mainly logistical reasons, especially here in Asia, that is a fact. So I think that should be the end of this talk. What happened? Doesn't move anymore. Okay, so that's the key point of this talk. Early intervention is the way to go. As long as you have the chance to see a patient with spasticity, you intervene early. Now, it's up to you whether you use high doses based on that University of Texas study. Thank you very much.